That's 30 seconds from my time. Good morning, everybody. Thanks for the GIS for this kind invitation. I'm going to be in the fence in the renal denervation, so I'm going to present the data in an impartial way. I have no conflict in relation to RDN. I do use it. I'm still finding my way in when and should I use it. So I'd like you to bear with me because some repetition, but I will reinforce some point in the critical appraisal of those trials. I'm going to review some of the evidence. I'm going to go over the guidelines, the most recent guidelines, position statement, and what are the current gaps that might help us in the future in finding the right patient for RDN. Major common problem, hypertension. Are we the right people to treat hypertension as cardiologists? Absolutely. But why we are skeptical about RDN? Because we are used to big outcome measure, mortality, cardiovascular mortality, and stroke. We have not seen this in any of the data related to RDN. The amount of untreated patients with hypertension who are not reaching target is huge, and the healthcare cost associated with that is also huge. We know that reduction of blood pressure of 10 millimeter of mercury has been clearly associated with cardiovascular outcome, stroke, and mortality. Have we seen that in the RDN? Probably not, because most of the trials are mainly to show us a treatment effect and efficacy so far. Now, I promise you I'm not going to go over the detail. I picked the one that in my mind, is more relevant to a practitioner to understand the treatment effect. But both current available therapy has a well-established program in showing you the efficacy. We had a setback, and as my colleague Dr. Kurdi alluded to, that there are setbacks. And whenever there is a trial that well conducted showed no effect, we always go back and look for why it did not show an effect. This is the first trial, randomized trial of the RDN, included patient in the first technology of the RDN, and basically did not show any meaningful effect. How did they decide the meaningful effect? More than or equal to 5 millimeter of mercury. RDN in the first iteration failed to show that. But then immediately people start to look back, oh, why didn't we show an effect? The ablation type, the ablation catheter, the changes in the hypertensive medication. Did they learn from that? Absolutely, because we can see a change in the design of the subsequent trial to try to reflect the mistake that has been done in the first trial. For me, the trial that as a practitioner, I should look for, we already approved the effect of medication, but let's see the effect on the medication. This trial was published 6 months, the 6-month outcome in Lancet, but this is the 36-month follow-up. Important to note that the randomization was blinded in the first 6 months, meaning nobody knows what he got in terms of sham or renal denervation. After the 6-month medication change allowed. Why did it allow? In order to show us, was there a meaningful effect for the RDN in the first 6 months and subsequently? More importantly, as a practitioner, I want to see if there is an effect in 36 months, if there's a residual effect related to the RDN. And that is the design of the spiral hypertension on medication. Also, the learning point in looking at the follow-up of those patients is important when you want to establish such a program to see what did the trial show or what did the trial use in their landmark times, 6 months, 12 months, and where do you expect the change? No difference in the baseline characteristic of between the two patients. They are hypertensive, stage 1 hypertension. Both are whether using a 24-hour or the office blood pressure measurement. The number of the medication, if you notice, in the first 6 months, there was no difference. But as soon as the 6 months allowed for a change in the medication in patients, you could see a significant increase in the amount of medication in the sham group in order to achieve control compared to the RDN group. Now, if you look at the 6-month mark, definitely there is a meaningful difference in the treatment effect where you are not allowed to make any changes, and subsequently with the changes, this margin of change actually reduced. But up to 36 months, if you look at the treatment arm compared to the sham, there was a meaningful difference in the blood pressure control. This applied to all blood pressure, mean 24-hour early morning, which has been shown to be associated with cardiovascular outcome, clearly favoring the RDN up to 36 months. Now, this effect also maintained when you look at diurnal variation in the blood pressure in relation to the RDN versus the sham. The amount of patients who achieved a blood pressure control in the RDN was 83% versus 43.8%. We'll talk about the margin of effect, but definitely there is an effect up to 6 months. Is this comes with a price? Absolutely, there is no significant safety concern, but is this enough? Is 3 months or 3 years enough? Probably enough in relation to immediate effect, but the long-term effect of the R ablation on the renal artery need to still be followed beyond 3 years. So the conclusion of the trial, meaningful blood pressure reduction, sustained up to 3 years. Other technology, I'm not going to talk about this in terms of how to conduct it, but it is included in the sum of the data. Similar design for their trial of medication, on medication, and resistant hypertension. The highlight in my review of their literature is they used a more lenient blood pressure and entry. Definitely, they all have a washout period in order to show the effect. The margin of the effect was comparable to the RDN. We're talking about 6 millimeters of mercury in all the 3 trials. But when we have so many trials, it's very important. I'm just going to skip to show you the pooled analysis of all the ultrasound-related technology, showing a meaningful difference in the percentage of patients showing or reaching a hypertensive, a controlled hypertensive, which was defined in this study as less than 130, 5/85. Similar to the RDN, there was no safety concern with the ultrasound. Now, I think when we have so many data, it's very nice that we have some authors who do some of the work for us and really do multi-level meta-analysis. This included most of the published approved system, ultrasound and the RDN, and showed clearly overall there is a treatment effect. We'll talk about the size of that treatment effect and whether you are in medication or off medication. Now, how much is this treatment effect? Very important for us as a practitioner. Why? Because what's a meaningful blood pressure effect that has been shown in mortality? I showed you in my first slide, 10 millimeters of mercury. Did we achieve that in RDN? In this meta-analysis, in the ambulatory systolic blood pressure, only 3.6. In the diastolic blood pressure, 2.7. There was no evidence to support that whether medication on or off, that upset or offset the effect of the RDN. This is another important meta-analysis, but this one included even the currently studied technology that's seeking approval. And similar to the previous result, when they analyze the data of medication or on medication, there is an effect for the RDN, which is a modest effect so far. It is important, and I'm sure my colleague, they're going to talk about that in their subsequent presentation. But for me, if I am reviewing an evidence, I want to see, does RDN work like all the medication we use in hypertension? You give it to people, and basically it has an effect. So we need some form of predictors. The important aspect that the trial provided to us, and it will continue to provide to us, is what are the patients that probably going to improve the most with the RDN. And this came from an analysis from the Simplicity, basically looking at patient in relation to the plasma renin activity. And they classified the patient as high and low plasma renin activity. And you could see that there is a marked effect of the RDN in patients who have elevated plasma renin activity at the entry level. In fact, when they quantify the effect based on the quartile of the elevated plasma renin activity, patient who has the most elevated plasma renin activity has the most effect in RDN. Moving forward to the position statement, in 2018, the AHA gave a supporting, but I should say a shy position statement in relation to the technology, because again, we are used to major outcome trials in hypertension that change mortality. This has not been shown so far in RDN, but For people with resistant hypertension, it gives the green light to try it, but using a shared decision making. I see the red light, I better hurry up. 2024 European guidelines 2B emphasize in high volume and shared decision making and resistant hypertension. Also, in the 2024 European guidelines 2B in patients who are having a high or elevated cardiovascular risk, who are failing to obtain a target blood pressure. Class 3 for patients who do have an GFR less than 40 because they were excluded from all trials of renal ablation therapy. This is important for a new center who are trying to establish a program for RDN. There are multiple societies who use this in their referral clinic, multiple criteria to screen the patient, mainly on the amount of medication, secondary causes of hypertension, but more importantly, which sometimes is lacking, is doing the pre-screening workup, CT scan, and some patient MRA, in order to define whether or not the patient is a candidate. So what are the issues that, in my review of the literature, I face? I could tell you that still there are a lot of unanswered questions. I have no concern about people who are doubting the use of RDN, but clearly we have established efficacy, modest effect in the blood pressure. We need to know who are the patients who truly is going to drive benefit, because some of us have patients who did not develop any benefit from RDN. And in summary, the current RDN technology provides a modest effect in reducing the blood pressure, safety profile already established, and there is evidence currently for an adjunct role, not as a sole therapy for hypertension treatment, and this needs to be highlighted clearly to your patient. Thank you.